thank you very much today for joining us. We did a bit of a straw poll to what area of genomics people wanted us to focus on. And the message that came back is people were quite keen to talk about some of the recent genetic diagnostics, in particular non-invasive prenatal screening and reproductive genetic carrier screening, as well as direct-to-consumer testing. So we've focused the initial 10-minute talk on those, and hopefully that's of interest, but at the end we'll highlight some resources that are more generally about genomics. Okay, so I will hand over to my amazing friend and colleague, Bronwyn, who is the world's best genomics educator and is here at very short notice. So thank you very much, Bronwyn, for joining us. Would you like to say anything more about yourself other than your all-round awesomeness?
No, I know that I don't have any conflicts, so that's good news.
There you go, that's very good. And that's me. So in this role, I'm as a clinical geneticist at Sydney Children's Hospital in Randwick. So I put up this page because when I say to people I'm a geneticist, often this is the kind of face that I get back from people, or there's a thought, oh, genetics, that's something I did a long time ago when I was training, but it's just really complicated. And so I'm hoping to try and give you some resources to soothe some of that anxiety, because so that's where we've gone. So a soothing guide on where to go for the curious, as I mentioned, a focus on carrier and prenatal screening. Then I'm going to hand over to Bronwyn, who's going to talk about direct to consumer testing. And then we'll highlight some key resources and further pathways and referral pathways at the end. So one of the things that I think is really important when I talk about genetic testing with my patients and when I talk to my students about how to talk about genetics is really that we are one amazing bag of variation. So we all are very, very varied in our genetics. So genomic variation is the rule rather than the exception. And the complicated bit that the labs and then us as clinical geneticists have to do is try and interpret that huge amount of variation. So these are the sort of analogies I often talk to with the families that I see, that if you are looking through our DNA code, you've had exome sequencing or whole genome sequencing, it's like you are lining up the old phone books right up to the top of the Eiffel Tower, or sometimes I use Sydney Harbour Bridge, it's apparently about similar size. And then through all of that, we're looking through each of the sentences in each of those books and trying to find the one or possibly the two critical little changes, variations in how our DNA code is put together that is an explanation for the person's presentation. But often when we get a report back, we're literally, the labs are sifting through thousands of variants, and they're often these days giving us somewhere on this scale between they really think it's unlikely that this is the cause, benign, to they're very confident it's the cause, pathogenic, but at least a third, if not a half of the time, we're sitting somewhere in the middle and dealing with a lot of uncertainty. And often what we're doing is actually almost working on a crime scene to gather bits of evidence to say whether a genetic variant is most likely to be the cause, or we can get it off the hook and this is not the answer and we haven't yet found the cause. And I really have wanted to reflect at this point that I'm involved with a project called Gene Equal, where we've been interviewing one group of people with genetic conditions that's often never had their voice heard, which is people with intellectual disability. My particular area of interest is around the genetics of neurodevelopmental conditions. And what a very strong message that came from that is how important the words we use as we are talking about genetics is. So this was Aaron, who has a mild intellectual disability, and he was there from a child hearing discussions about genetics that were happening above his head because he wasn't being included in the conversations, and the sorts of words meant that he had felt that he had a large part of him missing. What he did have was a tiny chromosomal change, but this was the end result, and he had internalized that, and that was part of, an overwhelming feeling for him that he was somehow different from the others. You know, we talk about the normal population. What is normal? So these are the sort of words we would encourage you to use when you're talking about genetics, and strongly were recommendations that came from the people we interviewed with intellectual disability. So talk about genetic chance rather than risk. For example, some people who have a genetic cause of hearing loss would never consider that a condition that they would stop a pregnancy for, or, you know, that's actually part of their identity. So chance is a more neutral word than risk. Also think about using condition rather than disorder or impairment. And I'm very strong to try and make sure I'm saying a genetic variant or change rather than a faulty gene. A faulty gene implies it's our fault. There's something that's less about us, or a mutation. And I think a really important thing whenever we talk about genetics is to be very careful about how we are framing the genetic test, not overselling what it can do, and also being very clear about the limitations. There's pretty rarely a genetic test that can completely rule out a genetic condition, because our genomics are so complex and our knowledge is still gaining every week about what the genetic causes of conditions are. So often, you know, this is a lovely infographic, and I'll show at the end where this comes from Australian Genomics, but these are the 4 possible outcomes of most of the tests. And it's really important when you're talking about a genetic test or a genetic screen to have an idea how likely these kind of outcomes are. So for example, for my you know, the group of patients that I'm most commonly seeing, and I'm doing exome sequencing, so looking through the coding regions of all the genes for children with a severe epilepsy or intellectual disability, the chance of getting a clear-cut answer is around 40 to 50%. But we're not getting an answer, which means it's a non-diagnostic test. It doesn't rule out a genetic condition, or we're getting a variant of uncertain significance in then about 60%. So even though we strongly suspect that there's a genetic condition, the test is not yet good enough, or our knowledge of the genetic causes are not good enough. And also this, this chance of an incidental finding, something that we find which is not the reason we did the test, is often around the 1 to 2% chance, and really to be really carefully discussed with families all of these possible outcomes before they're going into and making a decision about genetic testing. Now, I stole this from Bronwyn, and I love this because it's an image that's showing really how genetics is infiltrating every part of medical care. And so you need to be prepared, because whichever part of medicine you're practicing in clinical care, you'll come across people with genetic conditions or considering about genetic testing or genetic screening. So the first bit that we'd heard you wanted to talk about was about reproductive genetic carrier screen, and there's been a huge amount of press in this area over the last few years. And really a lot of this was from this amazing couple here who had a little girl who died of spinal muscular atrophy in Australia in 2017. And they really advocated that they were never told that both of them were carriers, or were given the option of having genetic carrier screening during the pregnancy, or before they conceived, to know that they were both carriers of this rare condition, but actually relatively common in the whole scheme of things. And what their advocacy has done, and you know, incredible clinicians around Australia, including here at Sydney Children, our colleague Michelle Farrer, have really pushed, is to get a comprehensive suite of responses to that, which includes carrier screening for spinal muscular atrophy, that it's on the newborn screening, and that there is gene therapies available. And this is a little video that Michelle loves to show, which she's showing. This is a child without her advanced therapeutics. Gene therapy would have died by this age, and now here she is managing to walk. So this is how quickly moving genetics is. So over the last couple of years, we've had a big project called Mackenzie's Mission, named after Mackenzie's, which was really to try and understand how we might implement population-wide reproductive carrier screening, and what are the ethical issues, and what are the counselling issues, and what are the practical laboratory issues that surround that in a really detailed way. And that's just wrapping up now, and some reports coming out. And what that has shown is in Australia is about 1 to 2% of reproductive couples in the general population, where they're not from particularly ethnic groups where you may consider they have a high chance of being genetic carriers, like, for example, Ashkenazi Jewish individuals, or from a community where they're consanguineous, that about 1 to 2% would have an increased chance of having a child impacted by a severe or life-limiting condition. And the sort of options then that having the choice of having reproductive carrier testing and then finding out that as a couple they are at an increased chance opens up these reproductive options around prenatal testing, pre-implantation genetic testing, for which we now have a Medicare item for. Very recently, we didn't used to do. Donor egg or sperm adoption or fostering, not having children, or this other possibility. And importantly, one of the groups of conditions that Mackenzie's mission was looking at was genetic conditions where knowing early means that there is the potential to plan a safe place of delivery, have a management plan around that baby, and maybe even start therapies. So back to that SMA story, I'd heard about a family recently where they knew that their baby was going to be affected in the pregnancy, but what that meant is they were in a very quickly moved to a hospital where they could get advanced therapeutics and amazingly gene therapy within days of that baby being born. So it's really changing that landscape dramatically. And if you look through the genomics and general practice, there's this practice point that many organizations, including the Royal College of Obstetrics and Gynecology, recommend that the most common genetic conditions, cystic fibrosis, spinal muscular atrophy, and Fragile X syndrome, should be offered to all couples in the population. And what's been very tricky is that been that advice, and yet people have to pay for the testing. So it was announced last year that as of the 1st of November of this year, carrier screening for those 3 conditions will be available on Medicare, but exact details of that and the exact details of how that testing will happen and is there any extra support around the counseling for that carrier testing, to me is not 100% clear yet. The other thing, and this will, I think, come up later, is around non-invasive prenatal screening, I would call it. And this was my main message about non-invasive prenatal screening, is it was designed as a test to screen for Down syndrome. So it's a screening test. It's not a diagnostic test. Actually, how it does it is slightly mind-blowing to me still. It's picking up it's actually picking up DNA from the placenta, or the developing placenta, the trophoblasts, that has gone across into the maternal bloodstream, and it's comparing that to actually some free DNA from the mother. And that's the sort of words that you might hear. They often talk about free fetal DNA. Actually, it's this trophoblastic or placental DNA that it's measuring, which means as a screening test, it's got false positives, it's got false negatives. False positives are often quoted about 0.3%, but it actually varies per condition. So the lowest false positive rate is for Down syndrome, but you have higher rates for the other aneuploidies. And there's other reasons why you may get false positive rates. Often these are quite complicated. There are potentials where the mother herself may have some of her cells with a chromosomal change. So she's got mosaicism. So some of her cells have got a standard set of chromosomes, some have got an extra set of chromosomes, and that's not affecting her because it's relatively low, but it can be picked up and be confused. You have to set a point, so it's a statistical test. Remember, it's a screening test, and you can have these very complex things, probably not to go into too much detail, where depending on where a chromosomal change or genetic change happens, you may see that reflected only in the placenta. Remember, that's the placental cells that we're looking at, or it may be a mixture. And you can also get false negatives, which means that the test is not actually, is falsely reassuring. So saying that the fetus is unlikely to have a chromosomal condition when actually it does. And there are some reasons there that can be given. And interestingly, that's much more likely for the trisomy 13 and 18, which is thought to be due to that having associated with a smaller placental size. So a practice point is that it is a screen, not a test, NIPS, not NIPT, but it is marketed as a test. It is also marketed as a good genetic screen. But this was from a paper I was looking at, which estimated that of all of the significant likely to be genetic or multiple congenital conditions at birth, if you actually look at what percentage are chromosomal or due to a single gene or we don't yet have an answer for, and then you look at what percentage of even those chromosomal changes would be picked up by NIPT, it's probably less than 1%, which is why when I'm seeing a family in neonatal intensive care and they tell me there's no chance their baby could have a genetic condition, or they're on the ventilator with their congenital heart condition and their cerebral anomalies and their distinctive features, and I'm saying we think we need to do more testing, but they're saying, but we had the genetic test, we had the NIPT, so there can't be a genetic test. And I think that's really important to say what it is. And it does not replace ultrasounds, which are super, super important. Also, you may have a test that's unreportable, and there can be some complicated reasons for that. Sometimes there's increased maternal cell-free DNA for, she may have an autoimmune condition or heparin or be of a higher body mass. And also you can get incidental findings, which was actually news to me, but I've had some colleagues where this has happened, where it's actually due to a cancer in the mother, and that's being picked up. So this is not what we thought we would signed up for when we did the screen, but actually comes out as a very important result. Now I'm going to stop talking, you'll be relieved to hear, and I'll hand over to Bronwyn. He's going to be talking about direct-to-consumer testing.
Thanks, Emma. I'm going to be very quick because this is, direct consumer tests, online DNA tests, they've been around for a while now. We're starting to kind of, almost live with them a little bit. They were a whole new thing when we started our research back in sort of 2015, trying to find out who was using these tests, what they were doing with them, and then developing online resources. So some of the resources that you'll see here come from what was called the Genomics study, which was Genomics insights from Australians to try and find out who was using these tests and what they were doing with them. Most of the useful parts of that now have been translated into resources that are available online and have just been updated, things like the Genomics in general practice. And so the practice points here come from that, which are saying that there is so much variability in these different online tests. And so you kind of really need to know what you're looking at before you can figure out how useful they could be. And that is a big buyer beware thing for people. So the way that it's come down for the GPs at this point is saying that there is limited clinical utility, but they might become part of clinical practice in the future. And there are the actual changes that they're looking for are often known as polygenic scores these days, and they are becoming a part of more mainstream medicine as we're understanding more about what those scores mean. So we wouldn't say no, but buyer beware at the moment is that there are a lot of tests out there and they are very, very variable. So the things that make them most variable is that the testing companies are everywhere. And in some cases, the companies have different standards that are required depending on where they are in the world. They might be using different populations to calculate the results. So it's not just about taking and looking at the different genetic changes in the DNA. It's then about looking at the frequency of them and trying to map them up with population statistics. And so the algorithms will be different depending on which of the testing companies are using with which population. And in general, they've got no patient context because they don't offer the opportunity to find out what that patient has done in the past and what they are presenting with. So the practice point in this case from the Genomics and General Practice is saying that the utility of these is actually very variable. If patients do actually want to pursue testing, it's best to try and opt for something that's a full service provider that actually involves the GP, at least in conversation, a referral by a GP, some test interpretation and some support on there, which is not necessarily what all of these companies offer. And then there are a set of questions really that you can ask and discuss with your patients. What are they looking to find out from the test? And some people are actually looking for an answer. And sometimes those tests are not the way to go about them, but they don't feel like they know any other way. What else would they do with that information? Have they thought about the impact of that testing could have on life insurance? Will the company actually help them interpret the results? And actually, do you feel like you could assist the patient in interpreting the results? There are a number of genetic counsellors operating now in Australia who are willing to look at these. We're working in private practice, so there are potentially other pathways. There are also what we're calling community practitioners. There are a number of naturopaths and alternative practitioners who will also support and facilitate this testing, which adds an extra bonus of complexity, but to be able to talk through these questions should help.
Whew, well done, Bronwyn, fabulous. So hopefully we've whetted your appetite around genomics, just highlighting that now we, all of our lessons 1 to 8 are live on the e-learning module, Rare Disease 101 Australia. And there's links to how to get to that from our Rarest page. We've got a full lesson on genomics that Bronwyn and I were very involved with, and we've gone in more detail around setting expectations, genetic counselling around tests, and where to go for more information. So I've highlighted some key resources here. The Centre for Genetics Education has got a lot of education aimed at health professionals to help support them around genetic testing, including genetic testing in pregnancy and direct-to-consumer testing, little practice videos, for example. Genomics Info from Australian Genomics has some fabulous infographics. If your patients like visual representations, which I do, they're a wonderful source to have. And there is this Genomics and General Practice, which is very comprehensive.